Effects of whole body electromyostimulation on resting metabolic rate, body composition, and maximum strength in postmenopausal women. The training and electrostimulation trial. Institute of Medical Physics, Friedrich Alexander University, Erlangen, Nuremberg, Germany, and also Department of Exercise Science, Truman State University, Kirksville, Missouri. Let's skip the abstract for now. Go on to the introduction. The change in body composition and the corresponding decline of functional capacity from maturity to senescence, even in healthy subjects, are of clinical significance. In the USA, each year, about 10% of non-disabled adults 75 years and older lose independence to perform the basic activities of daily living because of disability. After the menopausal transition, body composition changes considerably in elderly women. These changes include a clinically relevant increase in body fat together with a reduction of muscle mass. Both factors correlate with morbidity and mortality in this age cohort. Parallel to these body composition changes, strength decreases by 15% per decade after the age of 60. However, although exercise studies have observed favorable changes of body composition and strength parameters, because of physical limitations or a simple aversion, a large number of elderly subjects seem to be either unable to or unwilling to perform intense exercise programs. In this context, whole body electromyostimulation, WBEMS, may be a smooth alternative to demanding conventional exercise programs. Although the favorable effect of local electromyostimulation on neuromuscular parameters has been previously determined in athletes, healthy young and elderly subjects, the overall effect of WBEMS on body composition and strength in elder subjects is scarce. Also important, the feasibility and acceptance of this exercise technology is unknown in this cohort. Thus, in this pilot study, we determined the effects of WBEMS on body composition, strength parameters, feasibility, and acceptance in a group of postmenopausal women. Our hypothesis was that WBEMS exercise favorability affects body composition and strength in this cohort. Methods. Experimental approach to the problem. We performed a 14-week randomized controlled trial with postmenopausal women to address our hypothesis. To ensure that participants adequately performed the WBEMS exercise regimen, we included only women with a long experience of resistance training. Further, both subgroups performed the same basic exercise training described below. However, only the Verum group performed an additional WBEMS regimen over 14 weeks, March 2008 through July 2008. How interesting. I was in my uni during that time too. Endpoints representing our primary targets, body composition and maximal strength, were skeletal muscle mass, indirectly assessed by spirometry, resting metabolic rate, RMR, body fat assessed by skin fold measurement, and bioimpedance analysis, BIA, abdominal fat determined by waist circumference and isometric trunk and leg strength. The study design allows us to determine the additional effect of WBEMS training on the above-mentioned endpoints in comparison to an isolated endurance and strength training program. Subjects: 30 postmenopausal women 55 years and older living in the community of Erlangen, Nuremberg, and pre-trained during the Erlangen Fitness and Osteoporosis Study, EFOPS, or Senior Fitness and Prevention Study, SEFIP, exercise studies, for over 3 years were included in the training and electrostimulation trial test. Both studies were trial stalled focused on general fitness with special regard to bone parameters with a combined high-intensity endurance, resistance, and balance regime with 2 joint sessions with 2 home training sessions per week. Exclusion criteria. According to the manufacturer, were epilepsy, cardiac, pacemaker, grave circulatory disorders, abdominal or groin hernia, tuberculosis, cancer, grave neurological disturbances, inflammable disease, bleeding tendencies, medication, or diseases affecting muscle metabolism. The study was approved by the Ethics Committee of the University of Erlangen, Ethik Antrag 3777. All study participants were informed of the experimental risk and gave written informed consent. Figure 1 shows the participant flow during the test study. Subjects were stratified by age and randomly assigned to 2 interventions groups, WEMS and 15, or control, CG and 15 also. In addition to the endurance and strength training described below, the WBEMS group performed WBEMS training every 4 through 5 days, see below, whereas the CG were all asked to maintain their previous exercise training. Table 1 gives the initial characteristics of the WBEMS and control group. Procedure. Intervention, basic exercise program. The basic exercise program has been described elsewhere in detail. Thus, only a brief description is given here. The exercise program consisted of 2 supervised group sessions, 60 through 65 minutes, and 2 home training sessions, 20 through 25 minutes per week. During these sessions, 20 minutes of aerobic dance, 70 through 80% HR max, were followed by multilateral jumps, 4 times 15 reps, and either by 40 minutes of functional gymnastics and barbell exercises, 3 exercises, 2 sets, 6 through 12 repetitions at 70 through 85% 1 RM, or dynamic resistance training with strength machines, 12 exercises, 1 through 3 sets, 6 to 12 reps at 70 through 85% of 1 RM. Electromyostimulation. In addition to the basic exercise training, the WBEMS group performed a guided and supervised WBEMS training, MIHA, Bodytech, Augsburg, Germany, Figure 2. Every 4 to 5 days, the WBEMS equipment enables the simultaneous activation of 10 regions: upper legs, upper arms, bottom, abdomen, chest, lower back, upper back, including the latissimus dorsi, with the different intensities, Figure 2. Participants carried out 2 standardized WBEMS programs during a 20-minute session, Table 2. 15 dynamic exercises for all large muscle groups using a small range of movement were performed during WBEMS training. Exercises were designed not to cause physical adaptations in this pre-trained cohort. Current intensity of WBEMS progressively increased during the intervention period. Compliance with the WBEMS regime was determined after 6 to 14 weeks, and participants were asked to appraise the average intensity of a WBEMS session and the regional intensity of the WBEMS on a rating scale. Ratings perceived exertion are PE between 1, very low, and 7, very high. Attendance was recorded by training logs managed by research assistants. Testing procedures. Tests were carried out before and after 14 weeks of exercise by the same researcher at the same time of the day, plus or minus 1 hour. All assessment was determined in a blinded fashion. Height was determined with a stadiometer, and weight was measured with minimal clothing on digital scales. Body mass index was calculated as weight divided by height squared, kg meters squared. Excuse me. Circumferences were determined on several locations, including the waist, hip. Body fat was assessed by skinfold measurements, Lawns, Cambridge, Massachusetts, USA, at 11 anatomical sites: tragus, mouth, axilla, subscapularis, abdominal, subraelius, suprapatella, biceps brachii, triceps brachii, and gastrocnemius. Tests were performed twice. The mean value of both tests were included in the analysis, though coefficient of variation was less than 5.3% for this procedure. Multiple tester reliability. Resting metabolic rate was determined between 7 and 9 at a constant room temperature of 23 degrees Celsius, before and after the 14-week intervention, using indirect calorimetry after 12 or more hours of fasting. Participants were instructed not to participate in heavy physical activity or exercise 24 hours before the test and to visit the laboratory by car or public transportation. Participants rested in a supine position quietly for 15 minutes before the data collection and for an additional 15 minutes during which the data was sampled. Subjects breathed freely through the face mask with expired air analyzed using an open spirometric system, Oxygen Mobile, Shohoken, Pennsylvania. Coefficient of variance determined in a recent pilot study was 4.1% for this procedure. Maximum isometric strength of the trunk and leg extensors was measured with a Schnell M3 isometric tester using test protocol suggested by Tusker, though coefficients of variance were less than 4%, 3.1 for trunk extensors and 3.9 for leg extension for this procedure. A detailed questionnaire was used to assess well-being, pain frequency, and intensity at different skeletal sites, pre-study exercise levels, normal daily activity levels, disease and medication. The follow-up questionnaires additionally contain sections to monitor disease, incidence changes in disease severity and intake of medication, lifestyle changes, or sport activities outside the test training program. Statistical analysis. The sample size calculation was based on our main endpoint RMR to detect a 5% difference between the groups. 15 subjects per group were required for a 5% error probability with 80% statistical power, SD 5% dropout rate, N2. Baseline values were reported at means and SDs. Normal distribution was checked using Kogoromov-Smirnov test, and homogeneity of variance was investigated with Levine F test. Normally distributed variables, including differences within groups, were analyzed using by paired t-test, otherwise the Wilcoxon test rank was used. Changes between baseline and 18 months follow-up were reported as absolute changes. Depending on the data, Mann-Whitney U-test based on absolute changes or analysis of variance with repeated measurements were performed to check time group interactions. Between group differences were given an absolute difference along with 95% confidence interval, Table 3. All tests were two-tailored and statistical significance was accepted at p is less than or equal to 0.05 effect size based on the absolute difference between baseline and follow-up in the WBEMS versus the CG were calculated using Cohen's D, SPSS 16.0, SPSS Incorporated, Chicago, Illinois, USA, was used for all statistical procedures. Results. Overall attendance rate of the basic exercise program did not change compared with pre-study attendance and was comparable between both groups, about 80%, 22.3 plus or minus 2.0 total sessions. Attendance rate of the WBEMS training session was 98%. No incidences of medical significance occurred during the training sessions. Average exercise intensity per session was characterized as moderate to high, RPE 4.4 plus or minus 0.5. After 6 weeks, and increased 4.9 plus or minus 0.7 after 14 weeks of WBEMS exercise. Was described as moderate for all other regions, 3.9 plus or minus 0.3, 3.7 plus through 4.1. The perceived exposure significantly increased after 14 weeks of WBEMS training, 4.7 plus or minus 0.5, 4.2 through 5.4. The effects of the WBEMS program on primary and secondary study endpoints is given in Table 3. In summary, RMR significantly decreased in the CG, negative 5.3%, P is less than, equal to 0.038, and did not show relevant changes in the electromyostimulation group, negative 0.2%, P is equal to 0.991. Despite a moderate ES is equal to 0.62, no significant differences, P is equal to 0.095 between the groups were determined. Body weight significantly decreased in both groups, WBEMS 1.9 plus or minus 1.7 kilogram, P is equal to 0.091 versus CG 0.9 plus or minus 1.5 kg, P is equal to 0.025. However, changes in body weight over the training was not significantly different between WBEMS and CG. P is equal to 0.122, ES is equal to 0.62 after 14 weeks. Some of skin folds were significantly reduced in WBEMS. P is equal to 0.991 by 8.6%. A non-significant increase in this parameter was observed in the CG 1.4%, whereas differences between groups was significant. P is equal to 0.991, ES equals 1.37. Corresponding data were obtained for BIA measurement. P is equal to 0.991, ES 1.22. Waist and hip circumferences were also significantly reduced in the WBEMS, both by around 2.3%. In the CG, waist circumference increased non-significantly. P is equal to 0.106 by 1%, whereas hip circumference significantly, P is equal to 0.008, decreased by 1.3%. Significant between groups differences were determined for waist circumference. P is equal to 0.001, ES equals 1.64. Maximum isometric strength for the trunk and leg extensors of the WBEMS group significantly improved by 9.9%, P is equal to 0.015, and 9.6%, P is equal to 0.001, respectively. Both parameters decreased non-significantly in the CG trunk extensors, negative 6.4%, P is equal to 0.054, leg extensors, negative 4.5, P is equal to 0.106, whole body electromyostimulation and CG significantly, P is less than 0.01, differed in these parameters after 14 weeks. ES equals 1.53 and 1.43 respectively. Because we observed a low incidence of pain intensity and frequency at baseline, the lack of significant differences among WBEMS and CG for these parameters were not expected or unexpected after 14 weeks of intervention. Discussion. To the best of our knowledge, the present study is the first clinical trial that determined the feasibility and, with one limitation, the effectiveness of WBEMS on body composition and strength in postmenopausal cohort. Thus, we could verify our hypothesis up to the point that WBEMS has a significantly positive impact on overall and abdominal fat on strength parameters. However, lean body mass, LBM, indirectly determined via RMR showed a non-significant effect, P equals 0.095, ES 0.62 after adjuvant WBEMS. Compared with other studies with comparable duration, dropout rate was low. The attendance was excellent in the WBEMS group. However, one has to realize that our WBEMS group was related to rather individualized training sessions with one instructor and two participants. Thus, it may be rather the exclusiveness of the exercise program than its mode that leads to this exceptionally high commitment. Judging the overall effectiveness of WBEMS in the cohort of pre-trained and physically adept subjects is difficult. The focus of the study was to determine the effect of an adjuvant WBEMS program on a variety of body composition and strength parameters in a pilot study design. This may have limited us in several ways. First, we recruited a cohort of pre-trained women that were capable of realizing the prescribed perceived exertion rate of the WBEMS program. This proceeding may be suboptimum concerning the development of our endpoints. However, comparable to conventional exercise protocols, it was essential that the exercise intensity, i.e., current intensity, was high enough to overwhelm individual strain threshold. Secondly, exercise and control groups maintained their conventional exercise training to not disrupt the training continuity, especially of the control group. Although both groups performed the same basic exercise protocol with identical attendance, there may be synergistic effect that favored the results of the WBEMS group. Thirdly, we did not perform high-end body composition measurements, computed tomography, CT, or dual X-ray absorptiometry, DXA, to minimize the bureaucratic expenditure. Hence, greater changes in body composition might have occurred than we were able to determine by the precision of our measurements. Despite the aforementioned limitation, after 14 weeks of intervention, we determined positive WBEMS effects on all anthropometric and muscular endpoints. Although we did not establish a sedentary control group for reasons discussed above, differences between groups reached statistically significance for fitness, strength parameters, and total abdominal fatness, sums of skin folds, and waist circumference parameters. Concerning the primary endpoint, however, the WBEMS effect on RMR did not reach statistical significance. Resting metabolic rate was selected as our primary endpoint for two reasons. Primarily, from the methodological point of view, RMR represents a key determinant of the magnitude of fat-free mass, FFM. Thus, changes in RMR may indicate changes of FFM. Although FFM is a heterogenic compartment, muscle, organs, bone, and connective tissue, exercise-induced changes in FFM can almost exclusively dedicated to changes of muscle mass. Further, with 60% or 70% of subjects, RMR is the highest component of their daily expenditure, meaning the exercise strategies to decrease or maintain body weight or body fat should focus on FFM. Thus, although compared with DXA, magnetic resonance imaging, or quantitative computing tomographic QCT, RMR may be suboptimal parameter to determine muscle mass per se. RMR assessment additionally gives an insight into the basic energy consumption of these postmenopausal women. A central case for the failure of the study to determine a significant effect on RMR may have been a less than adequate statistical power, resulting in a higher deviation of the mean difference than expected, 8% versus 5%. Several reasons may contribute to this higher variance. A low reliability of RMR assessment may have been present. This factor, however, can be neglected because the CV of our RMR measurement was comparable with the corresponding studies. Changes of confounding factors with impact on RMR during the intervention period were determined by interview or questionnaire. However, no subject reported major corresponding changes. Also, all subjects corresponding changes. Also, all subjects followed the prescribed protocol, which meant no subject participated in heavy physical activity or exercise 24 hours before the test or visited the laboratory by other means than car or public transportation, such as bicycle or walking. Thus, the most likely reason for the higher individual variation and adaptability to WBEMS, negative 5.3 to 8.4%, may be either the exercise compliance in the WBEMS group or a high variation of the corresponding effect of WBEMS on the RMR in pre-trained postmenopausal women. Concerning the first issue, however, Although attendance was rather high in the WBEMS group, it was difficult to decide whether subjects realized the prescribed exercise intensity during the WBEMS training. Regarding the development of RMR, it is interesting that the WBEMS group maintained their rates, whereas RMR, the CG, significantly dropped. Although a systematic error concerning the spirometric assessment may be a reason, the quality control parameters of this procedure did not report this idea. A more evident reason for the change in RMR may be individuals' acclimatization induced by seasonal variations during a test and intervention phase on March to the July. Both groups reduced their body weight significantly, with only one subject per group listing an energy restriction diet as a reason. Comparable to the RMR, the reduction of body weight may be related to seasonal changes of nutritional habits and energy intake. Whether energy restriction was generally related to changes of RMR and body weight is difficult to conclude in their views. Stiegler and Cunliffe summarize the effect of energy restrictions and combined exercise training, endurance and strength type comparable to our basic exercise program. Dependent on protein intake, the authors determined that there was at least maintenance of the FFM after progressive high-intensity resistance training combined with an energy-restricted diet, 800 kilocalories with 40% proteins. In a cohort of overweighted subjects, Briner et al. Determined a significant reduction of body weight combined, 15%, with a marginal decrease of FFM, negative 1.6%, and a significant increment for RMR, 3.6%. In parallel, the low-moderate reduction of body weight in our non-sedentary CG should not result in a significant decrease in RMR. Besides a significant reduction of body weight in the WBEMS group, a significant decrease of subcutaneous body fat was assessed at 11 skinfold sites, along with a significant reduction in the abdominal body fat as determined by waist circumference assessment, was shown in the presence of maintenance of RMR. Reviewing the literature, there is a lack of studies determining the effect of whole body myostimulation on body composition in the elderly. Although some studies demonstrated an increase in muscle mass after myostimulation, no study has yet assessed the effects on total or central body fat. Concerning maximum strength changes, our WBEMS group that performed an endurance and strength type basic program together with a WBEMS program exhibited significant differences compared with a CG that performed an isolated strength and endurance exercise program. Most studies with untrained subjects confirmed our results. In one study, the isolated effect of local EMS on isokinetic quadricep strength was compared with an isolated EMS program and a combined stair climbing EMS program. Contrarily to our results, Paillard et al. Did not obtain significant differences concerning the strength changes between the groups. However, unlike our cohort, the exercise subjects were college freshmen, producing a consider age differential. One may argue that the difference between the isolated basic exercise group, CG, and the combined exercise of WBEMS group did not result in a higher training volume of the WBEMS group. However, this argument may be confounded by dose effect phenomenon in the studies of strength type exercises. In summary, in this group of pre-trained elderly subjects, a high acceptance of feasibility of whole body EMS training exercises was verified. Further, we provided evidence to adjuvant WBEMS exercise exceeds the effect of isolated strength and endurance type exercise for fitness and fatness parameters. Practical applications. It is obvious that an increasing number of elderly subjects are unable or unwilling to perform intense conventional exercise training regimes. The findings of the study demonstrate that the whole body EMS program performed for 20 minutes every 4 days is effective and feasible. Thus, we consider the application of this novel exercise technology an appropriate alternative for elderly subjects to favorably improve body composition and physical strength important for healthy and independent aging. As a result, WBEMS as a means of exercise training that focuses on body composition and strength parameters should be taken seriously into account by end users, physical therapists, and physical fitness instructors. Acknowledgements. We gratefully acknowledge the support of Mia Bodytech, Augsburg, Germany. None of the authors has any conflict of interest. Further, the results of the study do not constitute endorsement of the product by the authors or the National Strength and Conditioning Association. No funding was received for this work from the National Institute of Health, Wellcome Trust, Howard Hughes Medical Institute, and others.